Today we are looking at the Trump administration's most favored nation drug pricing framework, which the Council of Economic Advisors published on May 5, 2026, with a headline savings figure of nearly $600 billion over 10 years. The press cycle went where it usually goes. Medicare GLP-1 coverage, 90% list price reductions on Trump Rx, 17 voluntary manufacturer deals, the political contrast with the Inflation Reduction Act. All of that is true. None of it explains how the framework actually works or why it could fall apart. Today, we cover 3 things the headline misses. Stick with us through all 3 because they connect. First, the voluntary manufacturer agreements. 17 pharma companies signed MFN deals without legislation. No subpoenas, no mandates, no statute. Why would any CFO sign a deal that could crater their pricing across every U.S. payer channel? The answer is a statutory carve-out buried in Medicaid law, specifically in 42 U.S.C. 1396 R8 AC 1C, which excludes Medicaid supplemental rebates from best price calculation. Here is why that matters. Under the Medicaid drug rebate program, the basic rebate a manufacturer owes is tied to best price, which is the lowest price the manufacturer offers to essentially any buyer in the United States. If a manufacturer offers a steep MFN discount and that discount resets best price, the rebate liability cascades across every state Medicaid program, and it also drops the $340 billion ceiling price for every safety net hospital and health center in the country. In 2023, 340 billion covered entities purchased roughly $66 billion in outpatient drugs. The cascade is not theoretical. The November 2025 Generous Model, which stands for Generating Cost Reductions for U.S. Medicaid, routes the MFN rebates through the supplemental channel, which the statute already excludes from best price. CMS made this explicit in its published guidance. Supplemental rebates under Generous do not affect Medicaid Best Price and do not affect $340 billion ceiling prices. That single sentence is the reason 17 pharma executives signed agreements. The $340 billion cascade has been surgically isolated, but this architecture is fragile. It rests on an administrative interpretation that a future administration could reverse. It rests on a CMMI Section 1115A demonstration authority that is time-limited by design, and the parallel $340 billion litigation from early 2026, where the American Hospital Association successfully vacated HRSA's $340 billion rebate pilot nationwide, shows that courts apply serious APA scrutiny to administrative engineering around $340 billion. Generous is structurally different from that pilot, but the litigation pattern is a warning sign. Second, the data problem. The $529 billion prospective MFN savings number, the big headline figure, is built on IQVIA MIDAS data. Here is the problem. The report's own footnotes, specifically footnotes 26 and 29, acknowledge that MIDAS data reflects standardized list prices and invoice prices. They do not account for rebates or clawbacks. They do not reflect net prices realized by manufacturers. The entire MFN policy is defined in net price terms. The data underneath the projection are not net prices. The gap is bridged by a 30% convergence assumption, meaning the CEA assumes U.S. net prices decline 30% toward reference country levels over 10 years. Change that assumption to 20% and the headline drops to roughly $350 billion. Change it to 10% and the number barely registers. The assumption is doing essentially all of the work. Thomas Phillipson, who chaired the Council of Economic Advisors in Trump's first term, published a June 2025 paper arguing that when you measure across the full prescription distribution, including generics, which are about 93% of U.S. prescriptions, and focus on public payer prices, the U.S. price premium versus peer nations looks materially smaller than the headline comparisons suggest. That finding creates real tension with the convergence assumption sitting underneath $529 billion. Third, the GLP-1 Medicare expansion. The Medicare GLP-1 bridge starting July 1, 2026 is what gets covered in the press. The article argues it is a 6-month payment plumbing exercise. The durable mechanism is the balance model, a CMMI demonstration running from 2027 to 2031. Medicare Part D excludes weight loss drugs by statute. Congress has not changed that. Balance uses Section 1115A demonstration authority to work around that statutory exclusion for participating plans, with eligibility and cost-sharing terms negotiated directly between CMMI and manufacturers. Here's the detail that changes the read on voluntary. Balance only goes live if 80% of Part D sponsors opt in. At 80%, voluntary is effectively mandatory at scale. Plans that stay out face a coverage disadvantage in the fastest-growing drug class in Part D. The incentive structure makes non-participation economically very difficult. So the framework has three load-bearing elements: the best price carve-out through generous, the IQVIA net price gap underneath the savings projection, and the CMMI balance workaround for the statutory GLP-1 exclusion. None of these are hidden. They are all in the document. The gap between what the headline says and what the architecture does is where the real analysis lives. Subscribe to On Healthcare for Part 2 and the full analysis. Link below.